Good morning, everyone, and thank you for joining us today. It's my pleasure to introduce Dr. Johad Khoury, a physician scientist currently working as a postdoctoral associate in the section of Pulmonary Critical Care and Sleep Medicine at Yale School of Medicine. Dr. Khoury earned his MD from the Technion School of Medicine in Israel and completed his residency and fellowship training in pulmonary medicine, joining Yale in 2021. His research focuses on idiopathic pulmonary fibrosis, including the discovery of GPR87 as a novel pro-fibrotic target work that has earned recognition through awards from the Department of Defense and Boehringer Ingelheim, among others. In today's webinar, Dr. Khoury will be sharing how precision-cut lung slices, or PCLS, are used to model pulmonary fibrosis and explore new therapeutic strategies. With that, I'll hand it over to Dr. Khoury.
Good morning, everyone. Thanks for being with us today. And thank you, Chloe, for the sweet introduction. And I'll be discussing the precision-cut lung slices, or for short, PCLS, in pulmonary fibrosis. Please feel free to interrupt me to ask any questions during the talk. And of course, we'll also take questions in the end, but feel free also during the talk. So these are my disclosures, none. Today we'll be talking about the PCLS in pulmonary fibrosis and in pulmonary diseases in general. We'll talk about the methods of inflation of both human and animal lungs. We'll talk about the induction of pulmonary fibrosis in PCLS and the combination of cutting-edge technologies in PCLS, and also about the treatment testing in PCLS. As an introduction for pulmonary fibrosis, for those who are not familiar with disease, idiopathic pulmonary fibrosis, or IPF, is a chronic progressive fatal disease characterized by aberrant wound healing, leading to fibrosis and scarring and thickening in the interstitium of the lung, leading eventually for impaired lung oxygenation and impaired a transmission between the alveoli and the blood, and eventually leading to symptoms including cough and shortness of breath, eventually killing the patient within 3 to 5 years of the diagnosis. So models that we use in human diseases and human cells in pulmonary fibrosis, but in lung disease in general, we have basically 3. I'm not talking about animal models, but human models, which include 2D cell culture models, 3D cell culture models, including the ALI, air-liquid interface, and also the matrigel dome, and of course, our topic of today, which is the ex vivo models of precision-cut lung slices. The disadvantages of the first 2 models, the 2D and 3D cell culture models, that it can be either like single cell culture, or at most a combination of 2 or 3 types of cells. It doesn't maintain the structure of the lungs, and it doesn't have the regular or native cell-cell interaction. The ex vivo models came to provide a solution for this part. The PCLS maintains the architecture of the native lung, maintains the cell-cell interaction, and the cell-cell proximity. And it gives us all the cells that are in the lungs, including epithelial cells, mesenchymal cells, immune cells, and everything that is in the native lung will be eventually in the PCLS. So what are the advantages of a PCLS? As I said, it gives us comparable and precise thickness of the lungs that allows the cutting of very short distance, very short thickness. It enables to maintain the cellular viability of the PCLS. It maintains the cell-cell interaction and microenvironment. Because the diffusion distance is so low, the PCLS is between 200 to 500 microns, which we choose, and we can decide if to go as low as 200 or 250 or whatever we decide, up to a 500 micron, which also enables the cellular viability, and the cuttings will be identical eventually, maintaining comparability. The model is viable and dynamic, and that means that the cells can differentiate, can de-differentiate, can interact, and can also give us a hint of the dynamics of the cells, including stimulations. So as in comparison to cellular models like single cell type culture, which is only the interaction between a certain type of cells, the PCLS allows us to see the interactions between different types of cells in this viable and dynamic model. And it's indeed the backbone of various types of diseases, including airways, which showed us in the initial reports of the PCLS that the airways in PCLS can contract, can be dilated, as in therapies that cause a bronchodilation. It can be also a good model for cancers, inflammatory conditions, and fibrosis, which will be discussed also today. So I'll be discussing a lot of technical issues. Please stop me and ask me any questions during the talk. So starting from lung inflation. It's a very important step because the lungs are a soft tissue. It's a fluffy tissue that we cannot cut if it's not solid. In order to solidify the lungs, we need to inject them with a liquid material that solidifies when temperature changes. And the most common component that people use to inject the lung with is low melting point agarose. Agarose is a sugar. It's an inert component which does not influence the cells. When the agarose is warmed up, it turns into liquid, and when the temperature drops, it turns again into a solid, which enables us to cut the lungs in precision cuts. So to start from the first step, when we expect or when we receive a lung tissue, either it's a human or animal lung, first of all, we need to prepare the materials that we'll be using. So preferably, we should receive a big enough piece of tissue that will enable us to inflate it through the airways. The airway should be big enough to enable us to inflate. If the airway is so thin, we'll not be able to inflate through the airway, and it will make the inflation process very complicated. In order to inflate one lobe of the lung, we use usually between 500 to 700 milliliters of a low melt agarose. The percentage that we usually use is between 1.5 to 2% of agarose dissolved in a PBS. In order to prepare our materials for receiving lung, a lung that we should expect, it should be big enough to be inflated. The airway should be wide enough to be inflated. Usually for human lung, we should receive at least a lobe. Otherwise, the inflation will be complicated. In order to inflate one lobe, the volume of agarose that we use is between 500 and 700 milliliter of low melt agarose. We need an autoclave tray, pipette tips that suitable for the inflation depends on the lung itself, and autoclaved tweezers and clamps. Can you move forward, please? So first of all, we need to dissolve the agarose in PBS. The concentration that we use is between 1.5 to 2%, which will allow us to have a structure that is solid enough to be cut, but on the other hand, not too much agarose, which will interfere to the cell viability by itself. After we dissolve the low melt agarose within this range in PBS, we need to warm it up. We usually use a microwave. We heat it up until it's fully dissolved, that we don't see any more particles of white agarose in it. It will be totally transparent. Then we should let it cool down in 40 degrees water bath or a bead bath. If we use very hot a temperature agarose, it will, of course, kill the cells and affect the cell viability. After that, we need to expose the airway that we will be inflating. In order to do that, we need to be familiar with the lung anatomy. You will see the video in a minute, and I'll be discussing the details during the video. We usually, using a human tissue, we either inflate the lobar airway or the sublobar or subsegmental airways in order to inflate the whole lobe. If we are using an animal model, we should expose the trachea and inject directly through to the trachea till both lungs are inflated. We should drain the blood from the heart before the inflation if we are using an animal model. We cannot do that in human lung because we receive it as a single organ, and most of the blood will be drained anyway before we receive it. After we inflate the mouse or rat lungs, we need to secure the trachea with a string in order to prevent leaking back of the agarose. If we are using a human lung, we should also clump the airway that we used for the inflation in order to prevent the leak of the agarose back and to maintain the shape of the lobe. After the full inflation, we need to keep the lobe or the lungs in 4 degrees for up to 15 minutes in order to allow the agarose to solidify. Can you move forward, please? Can you hit play? Okay, so here we see the right lung. It's not running, Chloe.
Let's see.
You have the play. Yeah, it's now running. So okay. This is the right lung. This is my student inflating the right upper lobe. So she exposed in the bronchus to right upper lobe, and she is injecting low melt agarose with the pipette boy using a 10 ml pipette tip into the right upper lobe, and we'll see in the next how it looks like after being fully inflated. You can choose whatever lobe that you want in case that you have the whole lung. Of course, human organs are so rare and so precious. So,
I'm sorry.
So if in case that you receive only one lung, only one lobe, that's okay. You can still use it. If you use anything smaller than a lobe, you should expose the biggest airway that you can use and then inflate through it. It's fine. The video is about to end anyway. It was just to show how we inject in the bronchial airway in order to inflate the lungs. Can you move forward, please? Okay. So this lung is not cut. It's what we see is the interlobar fissure, the inflated and looking solid part, which is the upper part, is the right upper lobe. Underneath it, we see the right middle and the right lower lobe. As you can notice, the upper part, the right upper lobe, is fully inflated and looks solid, looks more like liver, while the other parts looks fluffy and looks soft. Can you move forward, please? So to your right hand, you can see the lung after it was cored. And by coring, I mean that we make cores out of the lungs. We use punch biopter, usually diameters that we use between 0.8 and 1.2 centimeters. it enables us to get big enough slides to use for PCLS. But on the other hand, the more diameter that you have, the less replicates that you have. It's a matter of a trade, like how many replicates do you want? But on the other hand, how many material, eventually RNA, cells, or proteins that you have from each slide. The bigger the diameter, of course, the more cells and cellular components that you have. But on the other hand, less replicates, because eventually the time limit is a limiting factor is the time in this case, because out of this right upper lobe, we had more than 50 cores. In order to cut 50 cores, it will take more than 24 hours of continuous cutting. And after 24 hours of the donation of the lung harvesting, the tissue is less viable, and we don't usually use it after 24 hours. So whatever we can cut within the 24 hours, this is what we'll use. So it's a time limiting factor. We use the solid parts of the lungs, and we insert the punch biopter. It's the same one as they use in scan biopsies, but just bigger diameter. When the lungs are inflated with agarose, you can just insert the biopter in the lung. It will make cores that we'll see in the next slide, and the rest of the lung will look like Swiss cheese. So this is what we do. Of course, in the left part, it's not the human lung. It's just to show how we take the cores out of the lung tissue. And in the middle, we see the core. This is 0.8 centimeter. I usually go a 1.0 centimeter diameter because it gives me more cells eventually to analyze. After we have the cores, we stick the core on top of the tube of the PCLS. The tube that you see here, it's made of two parts: the white part, which is plastic, and the outer part, which is metal, and they move on each other. So we stick the core on the white part using super glue. You need to watch out not to allow the super glue to leak over the metal part. Then the metal part is stuck over the plastic part, and it will not move. After sticking the core on the plastic part, we let the whole plastic part and the core to slide inside the metal part, and we cover the gap between them with low melt agarose, the same agarose that we used to inflate the lungs. And in order to make it solid, we use a metal piece which comes with the fibrotome. We keep the metal piece in -20, and just to put the metal piece around the tube for a few seconds, the temperature of the agarose will drop down, and it will be solid, and it will enable us to cut the precision cut lung slices. Go ahead, please. Okay, so after we have the tissue core ready inside the tube, we insert it in the tray buffer, and we insert the tray buffer inside the machine. We fill the tray buffer with a cold medium. This is not PBS. We used a cold medium. We'll discuss the types of media during the talk. And then we run the vibrotome, and it will do the cutting by itself. The only thing that needs to be done during this process is to take the PCLS from the tray buffer using this plastic loop that you see in greenish colored. We'll see it in a video as well. And this is the architecture that you receive. So a round, nice PCLS inflated that you can see the alveolar spaces, which will be filled of agarose, as in comparison to a more cellular tissue. For example, if we receive a PCLS from fibrotic lung disease, that will be more cellular than a just empty alveoli. Move forward, please. Okay, this is a video that you can run, please. So this is vibrotome in action. So we lowered the speed of the vibrotome in order to allow the video. It can be ran in different speeds, and it does the cutting by itself. The shaft of the vibrotome will move forward exactly in the thickness that that you set it for, and the vibrotome will be cutting. The only thing that you need to do is just to sit there and use this yellow loop in order to collect the PCLS. And just a heads up, if you are cutting a human PCLS, it can be very time consuming and you'll be sitting there for hours. Move forward, please. Okay, so the types of medium used in PCLS. So it depends on the experiment that you'll be doing and the types of cells that you are interested with. So to start, probably you should do a literature review over the experiments that you'll be using. The most common medium used in PCLS is DMMF12, 50% to 50%. In combination with penicillin, streptomycin, and amphotericin, because as you all know, human lungs are exposed to air, which can be, of course, contaminated. So in order to prevent contamination of the tissue, it's highly recommended to use antibiotics and antimycotics. We do use 0.1% FBS, fetal bovine serum. Why do we use low percentage of FBS? Higher percentages of FBS are toxic to epithelial cells, and for my study at least, and for a lot of researchers, we are interested in epithelial cells, and we do not want to cause intoxication for the epithelial cells. So this is a prototype of media that you can at least start with, and eventually test the cell types that you have. And if you want to change it, of course you may, but it's always recommended to read about what other people did in your field in order to choose the correct medium for your interest of experiment. Can you move forward, please? Okay, so one of the most important questions is how to maintain high viability of PCLS. So it's a combination of procedures that you can do and other components that you cannot control. First of all, try to start cutting as soon as possible after the lung harvesting. Some of us receive the tissue from collaborators that can be hundreds or thousands of miles away, so the shipments and the delivery can be time-consuming, which eventually lowers the tissue viability. As I said, after 24 hours, the tissue viability goes lower, and me personally, I don't use tissue that was harvested more than 24 hours ago. The second thing that you can definitely dictate is using a warm but not hot agarose, because the hot agarose will cause cellular damage and will kill a lot of cells. So after you warm up the agarose, it will be in around 100 Celsius degrees. So let it cool down. Don't rush the experiment. If you have a time estimation of the arrival of the tissue, just make the agarose hours before to make sure that the agarose in a suitable temperature to be injected. Don't use very hot agarose. Wait, let it cool down, otherwise you will damage the tissue. On the other hand, the exposure to the metal piece that we mentioned that you put on a cylinder tube, the time should be minimal. I usually do 12 seconds, and that's enough to make the agarose solid. After that, probably the temperature of the tissue itself will drop to very low temperatures, making the cellular viability even lower. Regarding the keeping the tissue in 4 degrees, it's very important. If you keep the tissue in room temp until you cut it, the cellular viability will drop. If you receive the human tissue from collaborators and it was shipped as frozen, the tissue viability will be, of course, near zero. So ask them to ship it on ice, not on dry ice, not on ice bags, because the tissue will be frozen and eventually dead. A promising report from a group from Hanover, which was presented during the ATS last year, 2024, they mentioned that they were capable to maintain the PCLS viable up to 21 days after cutting. They didn't share the type of media because the paper was not published yet. It's still not published. So probably in the future we'll have more knowledge about the components that should be added to the media to maintain a maximum viability. And after you cut the PCLS, it's best if you can use it immediately. If you cryopreserve it and thaw it, that will affect the cellular viability. There are some trials about what's the best method to cryopreserve PCLS. We still don't know, in short. So probably avoiding freezing and thawing cycles are best to prevent cellular damage and to maintain cellular viability. Can you move forward, please? Okay, so after you cut the PCLS, since I do a pulmonary fibrosis, I'd like to discuss it with you. So in 2017, a report from a group in Pittsburgh showed that we can induce pulmonary fibrosis in a human disease-free PCLS using a combination of TGF-beta, TNF-alpha, PDGF, and LPA. Adding these components, the full report is available, of course, in certain concentrations. It will induce fibrosis in normal disease-free human lung slices. You can see that in yellow, it's the collagen 1 component. And after 48 hours, you can see that there is more collagen in the tissue, of course, after 120 hours. And it does not affect the cellular viability. The cellular viability was maintained, although the tissue was treated with these components. And it just induces fibrosis. And it's a valid method, a valid model for fibrosis and PCLS. Of course, we can use also profound fibrotic PCLS if we cut IPF explants, but that's very rare to receive. So it's easier to induce fibrosis in this tissue. It's actually a model of an early to moderate fibrosis, as in comparison to very full-blown pulmonary fibrosis if you use a PCLS from IPF. Go forward, please. Okay, so what can we use a PCLS as a model in pulmonary fibrosis? So we can study the cell components and how it changes after the induction of fibrosis. We can, of course, examine the cellular interaction between the cells. Everything that can be done in a cell culture can be also done in PCLS, including protein analysis, RNA, microRNAs levels and changes. We can discuss the histology. After you terminate your experiment, the PCLS can be embedded and cut and then stained, including antibody immunofluorescence or immunohistochemistry. Can be used also for in situ hybridization. Everything that can be done to a tissue or to cell culture can be also done in a PCLS. But on top of that, the major advantage of PCLS that we can test drug efficacy and toxicity, as I'll be showing in the next few slides. Can you move forward, please? So this is an experiment that we did at our lab at Yale. So we had disease-free human precision cut lung slices, and we treated with either a normal medium or a normal medium with a fibrotic cocktail of the 4 components that we mentioned before. And we harvested the tissue every 24 hours up to day 5, which was the final day of the experiment. We saw the experiment was analyzed using using a single cell RNA sequencing, and we saw that after using fibrotic cocktail, a new cell type, which is aberrant basaloid cells, developed in the fibrotic cocktail condition. This cell type is evident only in a fibrotic tissue, but not in a COPD or in disease-free tissue. So after the fibrosis induction using a fibrotic cocktail, we saw that a new cells developed or differentiated into this type of cells. We saw that this is only in fibrotic cocktail, and it started, if you can see more in red, which resembles day 4 and 5 of the experiment. We saw that there is the gene expression drifted during the experiment, starting from day 1 through day 5. I'm sorry. My gene of interest, which is GPR87, I saw that in day 0 I didn't have any expression, and the expression started at day 3 through day 5, and also with the GPR87, a lot of the genes that are related to the development of pulmonary fibrosis, like NK-adhering, MMP7, and ITG beta 6, also were expressed more at day 3 through day 5, and it was more in the fibrotic cocktail than the control lungs. Can you move forward, please? So what I did using these PCLS, that I used a disease-free PCLS, just like in the previous experiment, and I exposed these PCLS to either a scrambled RNA, GPR87 siRNA to block the GPR87 RNA and to prevent its expression into protein. And as a positive control, I used nintedanib, which is one of the 2 drugs approved by the FDA to treat pulmonary fibrosis. And I saw that in the positive control and the GPR87 siRNA, the tissue in these conditions expressed less collagen, meaning less fibrosis, as in comparison to the control, while the tissue that was not exposed to fibrotic cocktail, it did not express a collagen. So the positive control and the treatment group were similar regarding fibrosis, and there was no significance between the trichrome staining of the collagen, while the control group that was treated with fibrotic cocktail expressed way more trichrome, meaning more fibrosis. That means that my target shows a therapeutic target indeed. Next, I took a PCLS from IPF tissue, and treated it with the GPRX7 siRNA or with a positive control. And I saw that both treatments lowered the amount of collagen in the tissue as measured also with trichrome staining, but also the collagen and the supernatant of these conditions were lower than the control group, meaning that the treatment effect is also to reverse fibrosis, not only to prevent the development of fibrosis in a fibrotic cocktail model. So last slide, please. So the take-home message that PCLS is a validated, reproducible tissue culture model that enables us to cut the lines in very precise, thin thickness that will enable to maintain it viable to run the experiment that we are interested in. We can run whatever models that we are interested in, whether a airway disease or fibrosis or inflammatory or cancer related experiments. The PCLS can provide a basis for molecular and cellular studies, as we saw in the last two slides, and it will enable us to run and maintain the tissue as in its native condition with its cellular interaction. It will enable us to expose the tissue to triggers and to drugs, and we'll explore the exposure and its effects. And finally, we can run any type of analysis that can be done with a tissue or a cell culture. It also validated in a PCLS. And with this, can you move forward, please? With this, I thank you all, and I'll be glad to have any questions.
If anyone has any questions that they would like to put in the chat, I can read them out loud for you. If you don't have any questions, or if you want to unmute and ask some questions, you are welcome to do that as well.
Also, you are free to email me. I'll put my email in the chat. Just need to see how it goes here. Yes. Okay, I'll put my email in the chat if anyone wants to reach out after the meeting. So yeah, feel free.
Great. So if you do have any questions that come up at any point, you are welcome to email Dr. Khoury. Thank you so much for your time and for your presentation in your webinar. And everyone, have a great rest of your day.
Thank you very much.
Thank you. Have a good one.
Bye-bye.